Benign esophageal neoplasms are exceedingly rare. Most occur in middle and distal third. They are usually asymptomatic and leiomyoma is the most common. Most commonly, esophageal tumors are malignant. Squamous carcinoma used to be the commonest along the whole length of esophagus and adenocarcinoma in the lower third, most on top of Barrett's disease. In the last decades, there was marked increase of adenocarcinoma, so nowadays the two types are almost equal. Predisposing factors to squamous cell carcinoma include smoking, which increases the risk by 5 times. Heavy alcohol intake increases the risk by 20 times. Long-standing achalasia predisposes to squamous cell carcinoma due to chronic food irritation. Similarly, esophageal web or esophageal diverticula if long-standing. Low vitamins, fruit and vegetable intake, caustic burns like the post-corrosive, irradiation, and Plummer-Vinson syndrome are all significant predisposing factors. In China and Far East and around the Caspian Sea, due to fungus which grows on food grains. Predisposing factors to adenocarcinoma are Barrett's esophagus and obesity. There is no familial predisposition in both types. Direct spread through the wall is called direct lateral spread, and the tumor invades adjoining organs, like recurrent laryngeal nerves causing voice change, or trachea causing malignant tracheoesophageal fistula, or aorta. Vertical spread is the creeping of the tumor submucosal up the esophagus or down to the stomach. Lymphatic spread to cervical, mediastinal, or abdominal celiac lymph nodes is not always segmental, so a tumor of the lower esophagus may metastasize to cervical lymph nodes. Blood spread occurs mainly to the lungs and liver, and rarely to bone and brain. Peritoneal implantation occurs when the tumor is in the lowest abdominal part of the esophagus. Dysphagia is the classic symptom. It is gradual and progressive, early to solids and in late stage to liquids. There might be associated history and symptoms of predisposing disease like heartburn of Gerd. Pain on swallowing called odynophagia also occurs. Hematemesis is rare. Hoarseness of voice is indicative of advanced disease due to recurrent laryngeal nerve infiltration. Respiratory tract infection with cough is due to aspiration or tracheoesophageal fistula. Physical examination is inconclusive at early stages. In advanced disease, which is actually the more usual, there may be signs of wasting, malnutrition, and cachexia. Hepatomegaly due to metastasis, and Virchow lymph node in the left supraclavicular fossa. Dysphagia is the most serious esophageal symptom, not only because of its association with malignancy, but with other diseases that need early intervention to prevent complications like achalasia. There is, however, a long list of the causes of dysphagia. Dysphagia should be investigated till a diagnosis is reached. The first investigation should be upper endoscopy with biopsy of any suspicious lesion. Although the history of dysphagia could be helpful in the differential diagnosis, it is not reliable, and all patients having recent dysphagia persistent for over 1 week should undergo upper endoscopy. The following are poor prognostic signs in patients with cancer esophagus. They indicate advanced disease and that the patient will not benefit of a radical surgery, namely esophagectomy. Palliation is the target in these cases. So, to improve the prognosis, early diagnosis is the main factor. The only reliable screening method is endoscopy, which is invasive, time-consuming, and economically not feasible on a wide scale. So it cannot be applied except in areas where the disease is of very high incidence. Only in some regions of Southeast Asia are there screening programs for squamous cell carcinoma. Patients who have GERD should be followed up endoscopically for the development of Barrett's disease, which is pre-malignant. Upper endoscopy is the best initial investigation for esophageal symptoms in general and when esophageal tumors are suspected in particular. Although it is invasive compared to barium swallow, for example, it is much superior to all other investigations in putting the diagnosis on the right track. It also allows for biopsy and other very sensitive procedures like endosonographic assessment of early malignant tumors. After endoscopy, further assessment for the malignant disease is needed. Cervical and chest CT for upper third tumors and CT chest and abdomen for lower two-third tumors. CT assesses the local spread, vertical and lateral, lymphadenopathy, lung, and liver metastasis. Abdominal ultrasonography might detect liver metastasis not seen in CT, peritoneal nodules, ovarian and pelvic deposits, and malignant ascites. Tumors found to be inoperable are best palliated by insertion of an esophageal stent endoscopically to relieve dysphagia. If the tumor was impassable to the previously done diagnostic endoscope, a gastrographene swallow is helpful to study the length of the stricture, its shape, and distance of its lower end from the esophagogastric junction. This information is crucial to the endoscopist who is inserting the stent. Esophagectomy is a major operation done mostly on malnourished patients because of the dysphagia. When esophagectomy is planned, preoperative assessment of the nutritional status should be done. In the severely malnourished or in patients who are going to take a 2-month neoadjuvant treatment before surgery while dysphagic, a feeding jejunostomy is done to improve the nutritional status before the major operation. Radical esophagectomy entails thoracotomy or thoracoscopic dissection of the thoracic segment with its adjacent lymph nodes. Patients with poor pulmonary function do not tolerate the procedure well postoperatively and are at high risk of death from pulmonary complications rather than the operation itself. So pulmonary function tests should be done for all patients who are to undergo radical esophagectomy. This and the following 2 slides demonstrate the T&M grading for esophageal tumors. Note that lymph node metastasis far away from the tumor is an M, not N. Esophagectomy is the only potentially curable line of treatment for cancer esophagus. However, those patients should be selected carefully. The operation carries a significant mortality and a high complication risk. So there is no place to subject a patient to these risks for palliative reasons. There is no place for palliative esophagectomy for cancer esophagus. Therefore, signs of inoperability must be detected to avoid unnecessary surgery. This slide lists the inoperability parameters. Radical surgery for cervical cancer entails sacrificing the larynx and part of the trachea, dissecting all the cervical lymph nodes, and removal of thyroid and parathyroids, leaving the patient with a tracheostomy, aphonic, and in need of extensive hormonal replacement. The prognosis is still poor. So most centers avoid this mutilating operation and subject the patient to radiotherapy, which fortunately affords very good palliation. Until the tumor shrinks under the effect of radiotherapy, the patient might need the insertion of a self-expandable metallic stent endoscopically to allow the patient oral feeding. These stents could not be placed if the tumor reaches up to the pharynx, and so some patients will need a feeding gastrostomy tube. For lower two-third tumors, inoperable cases are best palliated by endoscopic stenting and sending the patient for palliative radiochemotherapy. When stenting fails, a feeding gastrostomy is done. Operable cases who can tolerate radical operation after careful preoperative assessment should be offered surgery if they choose to, after consenting to its risks. Age is not the decisive factor, but the general and the cardiac and the chest conditions. Radical esophagectomy with gastric pull-up is the usual procedure. The operation might be preceded by neoadjuvant treatment, and this period is utilized also to improve the nutritional status and to correct fluid and electrolyte imbalances. The esophagus is removed with the cardia of the stomach and the part of the stomach along the lesser curvature down to the incisura. The part of the stomach along the greater curvature is therefore fashioned into a tube and its blood supply is preserved. The gastric tube is pulled up and anastomosed to the stump of the esophagus in the chest or in the neck according to the length of esophagus removed. A feeding jejunostomy, if not previously done, is added because we expect the patient to fast for more than 5 days post-operatively. Almost all patients are admitted to the ICU post-operatively, and some will need mechanical ventilation for few days. Once the patient recovers, adjuvant radiochemotherapy is started. This diagram demonstrates the idea of esophageal stenting. This diagram demonstrates the principle of esophagectomy with gastric pull-up. This diagram demonstrates the principle of a tube feeding jejunostomy. Respiratory complications are the most common after thoracotomy and less if the dissection was done thoracoscopically. During surgery, the right lung is deflated and ventilation is through the left lung only. Chest tubes are also inserted. The right lung may not inflate completely at the end of the operation, and basal atelectasis occurs post-operatively. Pain during inspiration from the thoracotomy wound and the abdominal wound as well shall cause shallow breathing, which contributes to atelectasis. Atelectasis may progress to basal pneumonia on one or both sides. Therefore, in the postoperative period, chest physiotherapy should start once the patient is off mechanical ventilation. Intubation and mechanical ventilation in the ICU are attended with increased incidence of bronchopneumonia. Pleural empyema may occur due to infection introduced through the chest tubes. Leakage is the second common complication, and if occurring in the chest, could lead to empyema of the pleural cavity. If associated with mediastinitis, the death rate is very high. Therefore, some surgeons prefer removing most of the esophagus, even if the tumor is only at the lowest part, in order to avoid anastomosis in the chest. Leakage in the neck is much less hazardous. Unrecognized injury of the thoracic duct during operation will lead to chylothorax. Other complications include bleeding, recurrent laryngeal nerve injury, and anastomotic stricture.